Hello, and welcome to Seton Premier Staffing. This module will cover seasonal nurse orientation. As a seasonal nurse, you're hired on a short contract, and therefore you do not attend network orientation. To supplement the information provided during network orientation, along with providing additional information that we feel is beneficial to you, we have created this module. This module goes in addition with the handout that you received, called Seasonal Nurse Orientation Resource Handbook. Please use that handbook as we go through this module to make notes, questions, and any additional comments you feel that are appropriate. Please also be aware that this module contains information that applies to all specialties. So I will make sure to clarify if it pertains to one specialty or all specialties when we go through the module. These are the objectives. So we'll start with Ascension's mission. So Ascension's mission is rooted in the loving ministry of Jesus as healer. We commit ourselves to serving all persons with special attention to those who are poor and vulnerable. Our Catholic health ministry is dedicated to spirituality-centered holistic care, which sustains and improves the health of individuals and communities. We are advocates for a compassionate and just society through our actions and our words. This is Seton's vision. As you can tell, there's a lot of information on this slide, so please refer to your handout. These are our values: dedication, reverence, wisdom, integrity, service to poor, and creativity. Here at Seton, we do have a shared governance model. So this, if you're not familiar with shared governance, it's where clinical nurses have a voice in determining nursing practice, standards, and quality of care. We do have a nursing congress that's comprised of nurses who are nominated by their peers within their own specialties to represent their interests regarding policy and procedures that affect day-to-day patient care. And each unit from every Seton site has a nursing congress representative. There are 8 specialty councils and 2 support councils that comprise the foundation of the Shared Governance Forum. Each specialty council, comprised of nurses from specific healthcare areas, meets on a monthly basis to discuss and improve specialty-specific education, policies and procedures, recruitment and retention, and professional growth issues. Nursing Congress is a meeting that occurs once a month. If you have a nursing concern or just want to give your feedback, you can attend any of the Nursing Congress meetings or specialty council meetings. There's also on the Professional Nursing Congress website an area where you can provide information. This is just a representation of the shared governance framework here at Seton. Seton and Ascension are Catholic health-based ministries. Because of that, we do have ethical and religious directives, or ERDs. So a brief history of ERDs is that in the 16th century, the Catholic moralicists began discussing ethical issues in healthcare. The Catholic Health Association was asked by the National Council of Catholic Board to write a uniform set of directives for the country. These ERDs have been refined through an extensive process of consultation with bishops, theologians, sponsors, administrators, physicians, and other healthcare providers. These are the purpose of ERDs. The first is to reaffirm the ethical standards of behavior and healthcare that flow from the Church's teaching about the dignity of the human person, to provide guidance for advancing the Catholic Church's social vision through healthcare practice and advocacy for the most poor and vulnerable. Second, the ERDs provide authoritative guidance for addressing some of the more common ethical issues facing Catholic healthcare today. And third, the ERDs are intended to provide decision-making guides for patients, families, and surrogates who may be faced with making difficult treatment decisions in many different contexts of healthcare delivery. ERDs are divided into 2 sections. And the 6 parts of the ERDs address common ethical issues related to the social responsibility of Catholic healthcare, the pastoral and spiritual responsibilities of Catholic healthcare, professional relationship, beginning of life, care of the dying, and forming new partnerships. And the 4 principles include promote and defend human dignity from conception to natural death, care for the poor, which should be expressed at every level of the organization in concrete action, contribute to the common good, which is realized when economic, political, and social conditions ensure protection of fundamental rights and foster human flourishing, and stewardship, which entails promoting equity of care, fostering good health in the community, using resources wisely, effective communication between healthcare providers and members of the community, and respecting subsidiarity. Seton does have an ethics committee, and these 2 ladies do sit on that committee. I will show you later in this presentation where to access this intranet site, but if you ever have a question in regards to any ethics concern, these are who you would reach out to. This next part is a scavenger hunt for nurses. During this part of the module, I will be showing you Seton's Ascension, Texas intranet website. This information is also provided in your handout. Some of this information will be covered in another module, so I will not go through it in depth. So I will get out of the PowerPoint and go to the Seton intranet page. So this is the Ascension, Texas intranet. You can access it from Internet Explorer or Chrome. Here in the middle of the page, you do have where they post different stories, things that might be interesting to staff. Further down, you do have information that just pertains to nursing. Here on the left-hand side, you have associate news. So again, different stories that pertain just to associates. Further down, you have Ascension, Texas in the news and popular post. Here on the right-hand side, you have emergency management, language services, event reporting, clinical links. And this mosaic is a blog that our CEO, Craig Cordola, posts every few weeks. So the first thing I'm going to cover is language services. There is a section later on in the module that covers language services, but I did want to show this to you now since we are on the intranet. Here in the middle, you do have information on an access decision chart, the PILS, which is in your packet, that is a decision-making criteria. Over here on the right-hand side, you have language resources, video remote interpretation, over the phone interpretation, and on-site or in-house interpreters. There are only 3 sites that have an in-house interpreter, those being Dell Children's Medical Center, Dell Seton Medical Center UT, and Seton Medical Center Austin. If you need to request an in-house interpreter, you click on that, and then you submit your request through Service Hub. When you click on this, you pick your site, and then you fill out the information. All sites have phones, the interpreter phones, the 2 handheld devices, and they also have iPads for video remote interpretation. For the video remote interpretation, if you need information on how to access it, that information is provided for you in your packet, but it is also here. There's also instructions on how to use the phones. The big thing to remember with language services is that anytime you use an interpreter, so be it for an assessment, for giving medications, discharge, consents, whatever it is, you need to make sure that you document that usage in the electronic medical record. It is extremely, extremely important that it is documented. This is a legal issue, so you need to include, if you know the interpreter's name, that's easier for the in-house interpreters. But if it's one of the video or phone interpreters, you need to include the number that they give you. So if it's 1, 2, 3, 4, 5 is the number, you need to make sure that that is documented and what was covered. Going back to the main intranet page, right here on the right-hand side, you have event reporting. If you click on event reporting, this will take you to our two event reporting systems, ERS and associate incident reporting. The ERS event reporting system is for any patient or visitor events, compliments, complaints, or grievances. So if you have a patient fall, if you have a medication error, anything like that, this is where it's going to be inputted. The second system is for associate incident reporting. So if you suffer a needle stick, a patient handling injury, or anything like that, this is where you go. You can either call this number, or if you scroll down further, click on this link right here, and that'll take you to the website where you can enter that information. Under clinical links, you have a few links here, such as Lexicomp, which is our pharmaceutical website, where you can go to get information on different medications, find out if it's compatible, and also patient education. You also have physician orders and protocols. While we do have an electronic medical record, there are still some order sets that are on paper and have not been inputted into our electronic medical record due to the complexity of the orders. Most units, if they do use order sets, already have those printed out and filed somewhere at their nurse's station. But if you need to ever come and look up one of the order sets, this is where you come. Up here at the top of the intranet page, you have different tabs. The first one I'm going to go to is policies. This will take you to Policy Tech, which is where all of our policies live. As always, it's a good idea to make sure that you're looking up a policy before performing a procedure, so that way you know what Seton's policy is. So I'm going to search for a policy. And I'm going to search up urinary catheter. So when I scroll down, I come up with urinary catheters, inserting, maintaining, and discontinuing in an adult. When you click on that, it is going to bring up the policy. So you would be able to review that and learn more about it. A good rule of thumb is whenever you find a policy is to click on this down arrow and click on Add to Favorites. Because it never fails that when you need to look up a policy that you know you've looked up before, you can't find it. So once you save it to your favorites, you can always come to your favorites tab over here on the left-hand side, and you can go down and find the policy that you had added. So that is Policy Tech. Up here at the top, you have web apps. You have the Ascension Health portal. You have event reporting and the High Alert program. The High Alert program is also mentioned later on in your packet, but I'm going to go ahead and cover that now. So you enter your information. The High Alert program is for patients that are either coming in with that have a history of suicide, that are drug seekers, that are frequent readmissions. And what we do is we give them a care plan and we put them in the system. And there's a notification that'll pop up in the electronic medical record that this patient is a high alert. When that happens, we go to this page here and we enter the patient's information. So that way we can pull that care plan. Going back to web apps, you have time edits, you have Language Access Service Hub, My Learning, pre-printed physician's orders, and Seton email. Under clinical, there are several things under here that are important. So starting off under reference, you have lab specimen requirements. If you can't remember what color tube a lactate is, or if a lactate needs to be sent down on ice. You can go to this website, type in the lab, and it'll pull it up, and it'll tell you what is needed. Going back to clinical, again, you have LexiComp here. The next one I want to show you is Nursing Reference Center. Nursing Reference Center is a website that you can go to find information out on anything that you can imagine. One reason why I like to point this out is this continuing education tab up here. As nurses, we have to have so many CEs every 2 years to renew our license. And Nursing Reference Center Plus does allow us to get free CEs, in order to meet our licensure. So going back to clinical, you also have pick requests. So if a patient needs a pick line, this is where we will go to put that order in. We do have vascular access nurses that go to all the sites and put these in. So you would be able to go in here and put the information for the patient, your stuff, and your patient, and submit. Once the PIC team gets this, they will more than likely give you a call to follow up to see how quickly is it needed and other information like that. At 2 of our sites, Seton Medical Center Austin and Del Seton Medical Center, we do insert midline catheters. Midline catheters are a long-dwelling peripheral IV. So they're not a central line, but they're not truly a peripheral. And it can be left in for up to 29 days. Information related to midlines is provided later in your packet, but this is where you would also go to request one of those midlines. And a midline does not need a physician order. A nurse can put that request in, but there are specific medications that can be given through it and can't be given through it. There's a job aid and a policy. So going back to clinical reference, you have point of care testing, your pre-printed physician orders, resuscitation programs. So if you need information on how to renew your NRP, ACLS, TNCC, this is where you will go. And also WOC nurse referrals. So we do have wound care nurses. They do have limited hours, so here are where their hours are. So if you have a patient that comes in with a community-acquired pressure ulcer or develops a pressure ulcer while in the hospital, this is where you will go to input that information to have wound care come see the patient. If you have a patient with a new ostomy, it's always also a good idea to have the wound care nurses come and see that patient because they can provide some teaching along with making sure we have the right appliance apparatus for that patient. If a patient needs a specialty bed, nursing can put that request in. So if you need help with that, just reach out to the charge nurse. Going further down the page under clinical practice, here's that ethics website that I mentioned. So this will take you to the ethics website and for more information. You do have different nursing practice and quality here. Patient family education. Here's your professional nursing congress. And then going down under department, you have brain and spine. There are several of our sites that do have stroke certifications, and so you'll find that information here, patient education and staff education. Also diabetes education, imaging, infection prevention, language services, oncology, orthopedics, pharmacy. Here is the SPS website, and then trauma. One thing about trauma that I do like to point out is that we do have adult and pediatric trauma guidelines posted. So you can go to one of these websites here, click on it, and it will give you different policies and information. So going back up to the top under Associate, again, you have your portal right here. Environment of Care, EVS, Human Resources. You do have your MSDS database. This website will take you to where you can search up different chemicals that are used in the hospital or different products that are used to find out what their rating is and things like that. You do have your network password self-service, so that's where you will go if you need to reset your password. Under network, I'm not going to cover anything in this one, but there is information under that and quality and results. So going back to the presentation, so I covered web apps, the intranet, clinical, associate, and additional websites. Again, a good rule of thumb is just to get in there and play around in the intranet so you know what kind of information is provided. So going into more detail, I am providing you as a reference the 2018 Hospital National Patient Safety Goals. So these goals is a way to improve patient safety, and they focus on problems in healthcare safety and how to solve them. I'm not going to go through these are a reference. This is the order of draw for multiple tube collections. Here at Seton, we do not have phlebotomists that go around and draw labs. It is either the patient's nurse or a nurse and the patient care technician that draw lab. So if it is a phlebotomy stick, then anyone could, either a nurse or a PCT can draw that. And if it is a central line, remember that it is nursing that draws. This is a reference for you for our glucose monitoring system. We use a Nova product called StatStrip. You will get checked off on this while on the unit. This is just for a reference. As I mentioned previously, we do have midline catheters at two of our sites, Del Seton Medical Center and Seton Medical Center, Austin. This is a reference on what a midline is, what it is not, how to assess and document, and frequently asked questions. This right here is information on our different central lines. I'm not going to go through this, but one thing that I will point out is that across the network, dressing changes occur every Sunday, and caps are changed every Sunday, Thursday. This is in addition to if a dressing is needed to be changed sooner due to drainage or anything like that. But all dressings are changed Sunday and caps are changed Sunday, Thursday. This is a reference for the trach dislodgement occlusion emergency management algorithm. It is in there for your reference. We do have trachs throughout the network, so it's always good to know. This is our resuscitation record. It is a paper form that is on the crash carts located on the units. So if we have a patient that a code blue is called on, this is the document that will be filled out. I provide it as a reference so that way you know what questions are asked and what information is needed. Here at Seton, we use a company called Stericycle to help with our pharmaceutical waste management. The big things to remember is that for the most part, medications or IV fluids can be disposed of as always that we have previously. But we do have two bins, a blue bin and a black bin, in which we can dispose of medications. A blue bin is for medications without a waste that don't need to be wasted in our Omnicell, or is not a chart. So such as IV antibiotics, a half of a pill of something will go in this blue bin. We do not throw it in the trash. In the black bin, there are certain medications that are considered hazardous. Some of those are insulin, nicotine patches, the Coumadin packaging. That all goes in the black bin. And these are more guidelines. So the next thing we're going to cover is isolation precautions. Here at Seton, we have 4 different types of isolation precautions, and these are what is used across the nation. They are identified based on color, so you'll know what kind of isolation a patient is based on the sign that is outside of their room. To request an isolation cart, you call down to the supply, and they will bring you up a cart that has your isolation gowns, masks, gloves, stethoscope, and any other information. So in addition to our standard precautions, these are the 4 isolation precautions. The first one we're going to cover is airborne. It is pink. And these are for patients known or suspected to have an infection with an organism that's transmitted by small droplets suspended in the air, i.e. TB. So if we have any patients that are, we're ruling out TB or have TB, we put them on airborne precautions. We put them in a room with negative airflow, and we wear our N95 particulate respirator mask. The next type of isolation precaution is contact precautions, or green. These are for patients known or suspected to have an infection or colonization transmitted by direct or indirect contact with patient or patient's environment. So our patients that have MRSA, active MRSA, or have a history of MRSA and have an open wound that cannot be contained, VRE, or any of those other infections. If a patient has a history of MRSA, but they do not have an open wound, or they have a wound but it is contained, so they have a wound vac, we don't need to put them on contact precautions. Next is the yellow contact precautions, and this is for patients that are known or suspected to have C. diff. So if we're ruling C. diff out, or if they have it, we put them on contact precautions in the yellow. And we want to make sure the big thing is that we wear our gown and gloves into these rooms and that we are washing our hands, because C. diff, as we know, can be highly contagious. And last, we have our droplet precautions. These are for patients known or suspected to have an illness transmitted by droplets from coughing, sneezing, or talking. So our patients that come in with flu or any of those others, and we want to make sure that we wear a mask. These are some various diseases and what types of isolation they need to be on. I talked about this earlier, but this is your reference for the language services. So we have our phone, we have our iPad, and we have our in-person. This is the access decision chart I had talked about, along with the PILS criteria. And your Insight video interpreting reference. Here at Seton, patients that are discharged from an acute care unit and eventually maternity, we make calls on them to ensure that they are transitioning well once they are discharged. So every patient that's discharged home with home health, or AMA gets a call within 72 hours post-discharge. And we are asking them specific questions such as, were they able to fill their medications, schedule a follow-up appointment, if they've had pain in their hospitalization, that their pain is managed. Through these phone calls, we have identified several instances where patients have not been able to afford medications, can't get a ride to their physician's office. And so when that occurs, we will escalate it to a nurse navigator who will help the patient get the resources that they need in order to help prevent them from coming back into the hospital. This next section is related to our suicide risk. This is for all nurses because suicide does touch every aspect of a patient's hospitalization, from the emergency room to discharge. So every patient that is admitted, so it doesn't matter if they are admitted in the ER or they come in having a baby, they are all asked these 3 questions. The form that I provided you is the paper form, but this is documented in Compass. So every patient is asked these 3 questions. Over the past 2 weeks, have you felt down, depressed, or hopeless? Have you had thoughts of killing yourself? Or in your lifetime, have you ever attempted to kill yourself? So they're asked these questions: yes, no, unable to assess, or refused are the 4 options. If a patient states yes to any of the questions above, the nurse or provider should be notified and complete a suicide risk assessment. If a patient refuses to discuss the questions or were unable to assess, so your patient's intubated or something like that, the nurse must document an explanation of the reason and any actions taken. So that's part 1. If a patient states no to all 3 of those questions, then you're finished. But again, if they state yes, then you're going to move on to the suicide risk assessment. This suicide risk assessment is documented on paper. It is not electronic at this time. So the initial assessment that's to be completed by the nurse is you're going to begin with questions 1 through 5 within the past in the past month. And then reassessment occurs every shift, and you begin questions 1 through 5 with "since I last asked." So you ask questions 1 and 2. In the past months, have you ever wished you were dead or wished you could go to sleep and not wake up? And in the past month, have you ever actually had any thoughts of killing yourself? Yes or no. If they say yes to question 2, then you ask 3, 4, 5, and 6. If no to question 2, then you go directly to question 6. If no to 1 and 2, proceed to page 2. So the directions are right there for you. And then you follow that and you go down the questions. The second page of that is then scoring to see if the patient's a high risk, low risk, unable to assess, refuses, or if they're kind of a moderate risk. So these are your interventions for if they're a high risk, low risk, unable to assess, or patient refuses. So if a patient is a high risk, if they're in the emergency department or inpatient units, we do have an observation documentation checklist. It is paper. Again, this is not on in the electronic medical record yet. So this form is filled out in addition to documenting and encompass your hourly rounding. So this form does not negate performing hourly rounding and documenting hourly rounding in Compass. So like I said, there's an emergency department one and an inpatient one. This is the emergency department one. As you can tell up here, you have observations, activities, and your interventions. And this is an example of one. So at 10:15, the nurse filled out did IF, which indicates initiated form, any other observations, activities, and their interventions and initials. These patients will have a one-to-one sitter, and that sitter can document and does document their observations on this form. But a good thing to remember is that the nurse every hour does have to come and assess the patient and initial behind the sitter that they did round on this patient. So again, you're performing hourly rounding on your patients, so you'll do that at the same time and document on this form. So the SJ in this example is the sitter and N is the nurse. So they just did a dash and N for nurse. So again, remember, for both the ED and inpatient forms, the nurse is responsible for initialing this form every hour, in addition to what the PSA or the sitter does. This is an example of the inpatient high-risk suicide observation form. A big thing to remember is that the ER1, and I forgot to mention this, is done every 15 minutes. So observation and assessment and interventions need to be documented every 15 minutes. For the inpatient, it is every 30 minutes. And again, the nurse is responsible for every hour initially behind the patient safety assistant. In addition to the suicide risk assessment, the observations documents, we do have a safer room preparation checklist. This, again, is documented on paper. And this is to ensure that rooms are free from items that the patient can use to harm themselves or others. But it needs to make sure that we retain items that help the patient to cope, self-soothe, and emergency items that might be needed for emergency patient management. So you'll go through the form and you'll just check off anything that was removed or facilitate in monitoring the following. If something is left unchecked, that just means that it's not appropriate for that patient. Moving into restraints, again, this is for all nursing areas. We have two different types of restraints, nonviolent and violent. If a patient is in violent restraints, they need to be in the ICU or the ED. Nonviolent can be on any of the other patient units. And this right here is just a guide on making sure that you're documenting appropriately. This form right here tells you how frequently you need to document, encompass, and receive your orders. As I had talked about earlier, we do have a high alert program. I had shown you where that website is. As a reminder, it was developed to identify patients who may frequently seek medical treatment for complex or chronic conditions, and those who are known to possibly be a danger to themselves and others. And these patients have personalized care plans to help with managing their treatment. So how you know if your patient is in the high alert program? Encompass on the banner bar at top, you'll see under alerts that it'll be a high alert 2. And also on their armband, it'll tell you at the top if they're a 1111, 333, or 222. So the 3 levels, a level 1 is attempted to self-harm or others in the hospital, and anyone with APD, Austin Police Department involvement while in the hospital. Level 2 is attempted self-harm while in the hospital. And level 3, complex needs, specific orders, frequent visits, and patients with nonviolent behavior. This is how to access. Next is Operation Safe Shift. So this is another initiative of Seton's to ensure that we are placing patients that could potentially harm themselves, harm others, have been verbally or physically aggressive towards staff, that we alert others of this potential for patient violence. So if we put a patient on Operation Safe Shift, these ensures that the nurse knows, or anyone that goes in the room, that you need to pay extra attention to the patient's nonverbal cues or signs, and that we have someone else going into our rooms with these patients. And this also ensures that security is rounding on these patients every so often to ensure that nothing is going on. And this is more information on Operation Safe Shift. This next one, don't miss a beat, pertains to acute care only at all sites, excluding Del Seton Medical Center, UT. So for the acute care units, we do have a centralized monitoring unit that is located at Good Health Solutions. So this means that all of our patient telemonitoring is monitored remotely. It is not monitored at the sites. So if we have a patient that needs to be put on telemetry, we need to call the centralized telemetry monitoring unit techs to give them the patient information, room number, their medical record number, the telebox number, and diagnosis. We also need to make sure that we are documenting it in Compass that we notified them. Again, this is information that you need to provide and make sure that you are notifying the CTMU. This next section is for critical care and acute care. So this is for patients that come in with heart failure. So any patient that comes in with heart failure or has a history of heart failure, we are providing them education on it. So on admission, we give them the heart failure manual. This is kept at the nurse's station and they get one. And this form right here is placed on the patient's chart to help nursing know what information needs to be covered with the patient when. So on admission, phase 1, which can be considered day 1, phase 2, and phase 3 is the information that is covered. In addition to the heart failure one, we do have a COPD one, which is very similar to the heart failure one, but this one has a lot more respiratory therapy involvement. Respiratory therapy will give the patient a manual and provide information. But for nursing, we need to ensure that the patient knows their zones, and working with case management that they have discharged and staying healthy. And this is the action plan that was given to the COPD patients. This next section for stroke pertains to all inpatient units, ED, and critical care. So this is a reference. I'm not going to go through it, but this is just ensuring that the stroke bedside swallow screen is documented and education is done on any patient that comes in with a CVA, TIA, or ruling out a TIA or altered mental status. So the big thing to remember is we need to perform a bedside swallow screen, and we need to document it before any oral intake is given. So that means that if a patient, before we give any aspirin, Tylenol, anything liquid, any food, we need to make sure that we have documented the bedside swallow. And that we're also providing the patient with education. This information is provided during your COMPASS EMR training, but this is, again, as a reference for you. That under ad hoc charting, you go to education, stroke, quality measures, and each one of these boxes needs to be checked, yes, that patient was provided education. This form right here is for ICU and ED. This is a reference for you for your post-thrombolysis thrombectomy monitoring, frequent vital signs. This is documented in COMPASS, but this, again, is just an example that I wanted to provide you, that we are making sure that we are documenting our vital signs as ordered, and that we are doing everything we need. This is for ED and can also be for ICU for TPA administration. Again, it's a reference for you. Some of our sites do see spine surgery, so this information is for the ICU and acute care. This is just care of the spine surgery patient. Again, it's a reference only and can be used to help you when taking care of these patients. We also have bone and joint information. Again, this is going to be more for the acute care units, but again, it's there for you as a reference. And this is a documentation checklist that is put on the doors for our patients, so that way nursing knows to ensure that we are documenting and assessing appropriately. This is for ED, ICU, acute care, and maternity, the 8 behaviors of hourly rounding. So it is the expectation that nurses are rounding on their patients every hour and ensuring that we are documenting that on the hourly rounding logs that are in the patient rooms. And that is in addition to documenting in COMPASS that we are performing our hourly rounding. Yes, I know it is documenting 2 different ways, but that is the expectation that we are documenting both in COMPASS and on the hourly rounding form. The document that I provided is just a reference for you to help you with those 8 behaviors of hourly rounding. One thing I did want to mention is that we also need to be ensuring that we are completing the care boards that are in the patient rooms every shift. So we do bedside shift report and acute care. I know ICU does it a certain way, their bedside shift report. NICU at Seton Medical Center Austin also does bedside shift report. But get into the habit of when you first go in to introduce yourself to the patient or do your initial assessment that you're going in and completely filling out the patient's care board. Nursing leaders do nurse leader rounding, which is they round on every single patient every single day. And one of the things they are looking at is the care boards, and they will notify you if the care board is not updated correctly. So good rule of thumb is the more information you can put on the care board, the better. This next section is specific to maternity. So this first one is the fetal heart algorithm. Again, this is a reference for you on Seton's fetal heart algorithm. At Seton Medical Center Austin, we do have what we call a Rapid OB Response Team, or ROBERT. This is for patients that are having eclamptic seizures, perinatal cardio-neuro instability, hemorrhage, emergency C-section will be called overhead to ensure that we get the right members of the team to the patient. This is C-section classification guidelines. Again, it's there for your reference. We also do nitrous oxide for our patients, and this is the patient education that is given to them. And then for all of maternity at every site, we use as team steps behaviors. This is the communication in terms of team steps, how to do it, and information in terms of that. So that is it for this module. If you have any questions or concerns, please feel free to reach out to the SPS Education team at sps-education@seton.org. And again, I want to thank you for joining Seton Premier Staffing, and I hope that your time with us is very enjoyable.